Hey guys, this is Dr. Linville here. Welcome back from your break. We're going to be going over the elbow complex. This is going to be in musculoskeletal 1 for the upper extremity. We're doing this in January 2017. Hope you guys enjoy. This is the shortest of about 4 different lectures in this series on the elbow complex. So if we move on here, the objectives, we want to review pertinent anatomical structures and kinesiology of the elbow complex, systematically present different aspects of an evaluation and examination of the human elbow in orthopedic cases. We want to begin to compartmentalize different quadrants of the elbow to assist in funneling down to your differential diagnosis. And we want to examine appropriate objective tests and measures for elbow cases. So we'll get into especially the quadrants of the elbow. We like thinking of it as a anterior, posterior, medial, lateral. That really helps us differentially diagnose conditions. Pain is usually associated with each of those compartments, point to certain things. So we will get into that. So anatomy review, the elbow and forearm complex is comprised of 4 joints: the humeral ulnar joint, the humeral radial joint, the proximal radial ulnar joint, and the distal radial ulnar joint. You can see the skeleton on the picture on the right here, and this all should just be review for you. Again, ligaments of the elbow. The main 3 are the medial collateral ligament, also known as the UCL or the ulnar collateral ligament, the lateral collateral ligament complex, which is also known as the radial collateral ligament complex, and then the annular ligament, which surrounds the radial head. Here we have different bony anatomical structures. This again should all be review for you. I want you to pause it here and review some of the bony anatomy. And again, arthrokinematics. So going back into our kinesiology brains, you guys thought you had you had gotten past that part of your curriculum, but it's always good to review this sort of information, especially because the elbow kinesiology seemed to be one of the most difficult parts for people to pick up and understand and conceptualize once we were doing it in kinesiology. So I've put these pictures on here. I also want you to review your kinesiology notes. And if this is something that you struggled with in kinesiology, you should take a little extra time here in your understanding of this material, because we will be testing you in much more greater depth and detail on some of the kinesiology of the whole upper extremity for your tests. So arthrokinematics, if we go from left to right on this slide, you can see that the ulna is going into extension on the picture on the very left, which would be a posterior roll and a posterior glide due to the concave-convex rule. You'll see that the anterior structures are getting put on stretch. That's the dermis or the skin, the flexor, elbow flexors, and the anterior capsule all getting put on stretch. And then you can see in the back the posterior capsule and the extensors are being put on slack. You're also getting some bony abutment of the trochlea into the trochlear notch there, and or the olecranon notch, excuse me. And so you get a hard end feel, which we'll go over end feels later. In picture B, you'll see that there's an anterior slide or glide and an anterior roll. That's again due to the concave-convex rule. And the opposite is happening, right? Flexors and anterior capsule are going lax, and the posterior capsule and extensors are going on stretch. So if we get into these little box pictures on the right, these go over all the rolls and glides of the humeral ulnar joint, and then the radial ulnar joint, as well as the proximal radial ulnar joint. So, and I should have said the humeral radial joint. So anyways, we go along here. We just went over the ulna, and really the radius and the ulna, when they're moving on a fixed humerus, they both roll and glide in all the same directions because they're both a concave surface. So the top 2 pictures just distinguish that for both. If we get into the middle picture there on the right, you'll see that they're looking at the radial head as it sits in the radial notch. You have an M and an L, that means medial and lateral. So then we go down to our bottom 2 pictures. As the forearm pronates, you get an anterior roll and a posterior glide. That's for pronation. And then as the forearm supinates, you get an anterior glide and a posterior roll. So this is, again, confusing for some people. It is something I have to review every once in a while, so don't feel bad that you have to review it. Just make sure that you know it, especially come test time. So rules to apply for joint mobilization. We know through our kinesiology on the previous slide that at different times and different motions there's different slides and glides. So I want you guys to review also the open and closed pack positions for all of the joints of the elbow. I've left these spaces intentionally blank for you to fill out, and I don't think you'll have any hard time filling this out. I want you to apply yourself in your own slides here. We will go over this in class. So let's get into the kind of the meat and bones of this presentation, which is supposed to be about examination and evaluation of the elbow complex. So the examination, the elbow is a critical part of the kinetic chain in the upper extremity. It's important for all functional tasks of the upper extremity. It's kind of that cool kink in the chain that helps you bring things to your mouth, or reach up and wash your hair, or even during extension when throwing a ball. So without the elbow, we would just have two poles for arms walking around, and we'd never be able to bring our hand to our face. So it plays a really, really crucial role in human mechanics and survival. So your physical exam, just like everything else, must include the following: range of motion, strength, palpation, provocative testing or special test, neuromuscular test, and then functional activities. The functional activities are actually, we would group those as functional tests, something that you can measure, that you can test again later to see if your patient has improved in their own function. So during the examination, you're going to get a subjective history. There are several questions you can ask to start gathering info to hypothesize a patient's pathology and impairments. You're going to look at their chief complaint, their age, gender, location of symptoms, which is very important for the elbow, and mechanism of injury. These are what we call your primary intake questions. Secondary questions could include their handedness, if they're right or left-handed, what their mechanism of injury is in terms of, is it a repetitive use injury or is it a traumatic injury? Do they feel any locking or catching? And then the length and time of their symptoms. Is this acute or is this chronic? We continue with the subjective history here. With your chief complaint, your age, gender, location of symptoms, and mechanism of injury, you can begin to infer how to conduct your examination. And what I've done here is put a picture of a cross-sectional slide of the elbow complex. And you can see in the actual picture, the top left corner of that picture, where they've created this cross-section, which is right through the elbow joint there. So I want you guys to pause it here and then try to examine and differentiate what these different structures are, because on the next slide, we'll be talking about the different quadrants of the elbow. So here we are, we have different quadrants of the elbow, and this for me is a great visual. And this cross pattern that I've put on this slide is not perfect, but it gives you an idea of the general structures that are in each of the different quadrants. So you can see that your posterior quadrant really doesn't have many anatomical structures there. You have your olecranon, you have maybe the distal humerus and the triceps and things like that, but not a lot of structures there. So when it comes to differentially diagnosing, there's only several things that can cause pain or impairment in this area. Meanwhile, the anterior and the medial compartments are chock full of different anatomical structures. Bony anatomy, ligamentous, we have even vascular structures, neurostructures, and not to mention fascia and all these things that help keep everything held together. And then the big thing in the lateral compartment is the radial head, and then you can see the annular ligament, which is marked by number, it looks like either 19 or 20, that's securing the radial head. So again, I would pause here and try to identify as many structures as you can at this point. So when you're looking at your subjective history, you want to ask the following questions. Make sure you ask these. This is actually referenced in your Dutton book as well. Which activities or arm positions aggravate your condition? Does twisting or grasping different things, different shapes and sizes, are those aggravating factors? Is your pain constant or is it intermittent? And we can also talk about, is your pain constant and variable, meaning it's always there but it changes in the VAS scale, or is it intermittent and variable? And a lot of times what people will say is, hey, when I'm not moving my arm, it feels okay, there's no pain. But when I start to move it, that's when I start to get a lot of pain. Are there any associated neck or shoulder pain with your elbow condition? You want to make sure you clear the cervical spine. This is extremely important. You don't want to miss a cervical spine injury that's giving you radicular symptoms to the elbow. Have you noticed any sensory changes, paresthesias, or muscle weakness? This may be suggestive of a spinal root injury or a peripheral nerve injury, and really around the elbow, if it's a traumatic thing, you might be able to infer that it's a peripheral nerve injury, like a crush injury or something of that nature. How is the condition affecting the patient's function and recreational activities? You want to make sure you dive into this so you have a clear goal in mind of what you want to get this patient back to. Has the patient had this condition before? A lot of times what we see, and this is the case for low back pain as well as in elbow cases, is you can have acute pain, you can have, which turns into chronic pain. Technically, the literature suggests that chronic pain is anything 3 months or greater. And then you can also have acute on chronic, meaning they have pain for several weeks, it goes away for a month or two, and then it comes back for several weeks. So you have kind of this waxing and waning of pain. Number 7 here, you want to ask them about the past medical history and surgical history. Things you want to look out for are obviously previous elbow surgeries, if they've had any pain in their elbow when they were younger, if they ever fell and broke their arm, if they had cervical spine surgery. There's a lot of things that you want to know that might be related to their elbow pain. And then, of course, excuse me, any medications that your patient may be taking. So we look at the systems review. You want to look at the vascular and neurological symptoms because these are very common in the elbow complex. Excuse me. And what you notice is, if we go back to that quadrant picture, which you could stop and do now, you'll notice all the neurovascular structures there. And this is also why our special tests for the elbow and upper extremity in general we have these special tests because we can replicate a lot of these symptoms with those. Reproduction of the patient's elbow or other symptoms with cervical spine motion rather than elbow movement is a strong indicator of a cervical or upper thoracic source. Again, we've kind of touched on this, but I also want you to clear the shoulder. A lot of times patients will complain of lateral elbow pain, which they say runs down their arm to their lateral elbow, and it's usually from the shoulder or rotator cuff first. It's just a source of referred pain. There are some systemic causes of insidious onset of elbow pain, and these could include gout, infective arthritis, or vascular disorders such as a Volkmann's ischemia, which is not a great thing. If we look at examination, this is where we're going to look at our objective section of our exam. This is our test and measures. What we're going to go over is going to include your observation, your palpation, your active and passive range of motion, resistive testing, your neuroscreen, a functional assessment, and then, of course, joint mobility. So elbow complex, we're going to look at observation first, and this can be done at the moment you set your eyes onto a patient. You must be able to visualize both arms. Observation includes looking at scars, deformities, swelling, asymmetry in either size or positioning of the arm, discoloration. You're going to look at their carrying angle, and then if they have any weird muscle hypertrophy or atrophy. And a lot of times what these patients will do, if they have an elbow injury or they're just out of surgery, they'll be in a sling. They'll be in that guarded position while they'll have their arm close to their body. So just make sure you're looking out for all these things. We are going to review the carrying angle. The medial aspect of the trochlea extends more distally than the lateral aspect, which creates slight lateral deviation from midline. The axis of motion is superior and lateral. This is called the cubital valgus, also known as the carrying angle. Again, normal carrying angle in all humans is around 8 to 15 degrees. In males, it's a little less, and in women, it's a little higher. You can review your kinesiology notes on why there's differences. We won't dive into that for this lecture. You also have the opposite occur, which, as you look at the picture here, could be a varus deformity, which is also called a gunstock deformity. If we look into palpation now, there's so many structures in the elbow you can palpate, and it's all in such a confined space. So bony structures and muscles, I've broken these two groups. You can palpate your medial epicondyle, olecranon process, lateral epicondyle, the supracondylar ridge. You can try to feel for the joint line, and then of course the head of the radius. The high money targets as far as muscle goes are your biceps brachii, the distal biceps tendon, your brachialis, brachioradialis. You want to look at the common flexor pronator tendon, which goes into that medial epicondyle, the common extensor tendon, which goes into lateral epicondyle and is important in diagnosing like lateral epicondylalgia. And then, of course, you can look at your supinator, your triceps, and you can search around and try your best to feel the anconeus, which I try to get a picture of them doing that in this picture. So notable palpable structures in their quadrant. This is a great slide. It may be on your test or may not be. So again, we're looking at this quadrant of the elbow, this cross-sectional area, and I wanted you to pause it earlier to try to come up with as many as you could, and now we'll compare it to what you had earlier to what I've listed here. These are, of course, those high target, high money structures that we're looking for that are commonly injured. So in the anterior compartment, you have, of course, your elbow flexors, your distal biceps tendon, and then the antecubital fossa, which houses some of the neurovascular structures there. In the medial compartment, and we're going in a clockwise fashion here, the medial compartment, you have your ulnar nerve, your UCL, the flexor pronator mass or tendon, and then the medial epicondyle. Again, as we notice in the picture, in the posterior compartment, there's not a ton of structures. So you have your elbow extensors and really your olecranon process, and those are the two most. You also have a bursa as well on the olecranon. So you might want to add that one in. The lateral part of the forearm, you're looking at your wrist extensors, the LCL, your annular ligament, radial head, and the lateral epicondyle. As we dive in more into our examination here, we've already gone over observation and palpation, so now we'll look at your active range of motion. We're going to look at the osteokinematics. The normal range of motion for the elbow is anywhere from 0 to 10 degrees of extension, or what we would call hyperextension. Your elbow flexion is anywhere from 120 to 150 degrees, and those people with more adipose tissue will have less range of motion due to soft tissue approximation, but anywhere from 120 to 150 is appropriate. Your total arc of motion then ranges from about 10 degrees of hyperextension to 150 degrees of flexion, giving you roughly 160 degrees of total arc of motion for the elbow. Again, we look at this in the supination and pronation. You can see the numbers there, again, for approximately about 160 degrees of motion into pronation and supination, the transverse plane. Your elbow complex, we'll look at the capsular pattern here, or like joint capsule, right? The capsular pattern at the elbow is characterized by the limitation of more flexion than extension. So typically people can give extension back better than they can get flexion back. We don't really know why that is, except the capsular pattern tightens in a particular way, which limits those motions. So more limitations in flexion than extension. If motion restrictions are present, the nature and location of the motion barrier and the relationship of pain to the motion barrier should be noted. I mentioned earlier we're going over end feels. Flexion, you have soft or a compliant end feel, suggesting soft tissue approximation. Extension, if you guys go into extension right now, you can feel a hard or rigid end feel, suggesting bony approximation. And I want you guys to look up what pronation and supination might be. And then also, you might want to check your ulnar adduction and abduction end feels, meaning taking the arm into both your valgus and varus testing. As far as resistance testing goes, the elbow flexion, I have this flow chart from your Dutton book. Elbow flexion is nerve roots C5 and 6, elbow extension C7, and forearm pronation supination C5 through C7. And then you also want to look at your wrist flexion, extension, radial deviation, ulnar deviation, and digit flexion extension. We do this similarly to when we do our RIMS, our resistive isometrics, during the shoulder exam. You would do similar testing here. And again, then you could dive into manual muscle testing if you notice weakness in any of the following areas. But I like this chart a lot because if you do have pain or maybe weakness with resisted testing into each of these areas of forearm motion, then it might guide you in terms of your differential diagnosis into what may be a cause or source of the discomfort or weakness. Of course, if you look at flexion, that's the easiest one to kind of look at. You have the patient in 90 degrees of elbow flexion and you ask them to resist you pushing them into extension. Well, you can infer that it might be a lesion of the biceps brachii, the brachialis, or the brachioradialis. And maybe one you don't think about much, which is a weak elbow flexors, is the wrist extensors. So just something to think about there. As far as your neuro exam goes, there's just a few nerves that provide the major sensation to the elbow in the scan and all that stuff. So you know dermatomes, and you see the bottom bullet there. I want you to review your dermatomes and your deep tendon reflexes. We will go over that and kind of quiz you guys. But there's certain nerves: the radial nerve, the lateral antebrachial cutaneous nerve, and the medial antebrachial cutaneous nerve are the main nerves that provide sensation to the skin around the elbow joint. So I want you guys to find the nerve roots associated with those, and then also the area that they are innervating. When we look into functional assessment, this as an early PT was probably the hardest thing for me to come up with in terms of my exam. You want to find a what we would call like an asterisk sign, something that you can test and retest to see if your treatment is making them better, or something that you can test at the initial evaluation, and then after several sessions of physical therapy and home exercise program, if they've improved on this functional test that you can test at that later time or during your reevaluation. So functional tests serve as a way for clinicians to track measurable functional changes over time. That's one of those buzzwords. We'll get into that in class if you guys want to. But some of these can include grip strength, reaching, lifting, etc. Right? So anything that you can think of, I have several functional tests, and we can go over them. And if you want me to talk to you about those in class, we certainly can. But different tests that will stress a patient's entire upper extremity, but also you can get a sense of what the function of the elbow is within those tests. These can include physical or functional tests and outcome measures, right? Because outcome measures is a way that you can objectively get a sense of the patient's function based on their own personal beliefs of their arm. So appropriate outcome measures for the elbow include, but are not limited to, the following. These are the ones that I've seen and used the most in clinic. The dash, which is the disability of the arm, shoulder, and hand. The quick dash, which is just a shorter just a shorter version of the dash. But I love this one because it has your ADL, work, and sports subscales, so you can kind of get a real sense of where and what areas of life is this patient having difficulty. And a lot of times in our sports cases, we'll have patients come in their ADL and work subscale, they've scored 100% function, and then their sports, they score 0, right? So that really gives you a sense of where they're at in their life and what things are important to them. And then you have the ASES, which is American Shoulder and Elbow Surgeons Elbow Outcome Score. This measures function independently of diagnosis. So I believe the other ones do as well, but those are more involved in the entire upper extremity. The Elbow Outcome Score is made specifically for elbow patients. Now really one of the last slides here, and this is one you can pause or even look in your Dutton book, but you're going to look at normal or excessive active range of motion without symptoms. This is kind of just a flow chart of your exam. You provide passive overpressure, If they have an abnormal end feel, then you go down this way. Normal end feel, you go down this way. I want you guys to kind of just pause this and look through it and try to think, if you were seeing a patient that was right in front of you and you provide passive overpressure, if they had a normal end feel, what would you do next? If they had an abnormal end feel, what would you do next? And really try to put yourself and imagine that you're in a PT's shoes, maybe that you've observed before, or try to get a patient in mind that you've seen, and kind of go from there. We can, go over this in much more detail if you guys would like in class. So I just want to thank you for your patience. Basically, what's next is we'll go over differential diagnosis. There's a 2-part lecture series on the differential diagnosis of the elbow. We'll also have a lecture about special tests. And, of course, in lab and in our classes, we will go over all the special tests and answer any pertinent questions that you have. And then, finally, we'll go over case studies. And with this lecture and then these 3 that we have listed here, as well as answering questions that you have through email, you can get in touch with me anytime. We will prepare you for your first exam on the elbow complex. So without further ado, I want to thank you for your time, and we'll see you in class. Thanks, guys.